I have nothing to disclose. I wish I did, but I don't. Some of the objectives, we're going to talk very briefly about ARDS, and then these in order of complex states from high PEEP to recruitment maneuvers, APRV, which is very commonplace, prone positioning, nitric oxide, our neuromuscular blocking agents indicated. How about high-frequency oscillatory ventilation, and then ECMO. So this is a 40-year-old man. This is a patient that we took care of a couple months ago. He fell about 35 feet from a palm tree. He presents it to us as a trauma code. He has severe traumatic brain injury, extensive chest trauma, multiple pelvic and long bone fractures. He's taken to the operating room by one of our partners for a highly messed up abdomen, and then he's transferred to the trauma intensive care unit after damage control laparotomy. So this is his chest x-ray. For the surgeons in the group, you're probably not so much concerned about the pulmonary contusion as you're thinking he'd be a good rib plating candidate, but we're not going to talk about that today. So he's got a pretty significant pulmonary contusion on the left. His ribs are all banged up. Not too bad after falling 35 feet, right? So after the operating room, we put him in the trauma ICU. We place him on conventional mode of ventilation, which at our institution's assist control. You could easily put him on SIMV or pressure control or any other myriad, but we opt for assist control. A little bit of PEEP because we think this is about to be a problem, and FiO2 around 50%. We start to realize over the next hour or two that his compliance is becoming a problem, right? So tidal volume's down, airway pressure's up. We start to really start to play with the ventilators. Peak airway pressures are now a little on the high side. So now what? Spend a few minutes, tell me what you think you might do, but I'll tell you what we ended up doing and what we probably should have done. So ARDS, we all are familiar with this. It's an inflammatory disorder of the lung parenchyma. There's impaired gas exchange resulting in hypoxemic respiratory failure. The good thing is it only affects about 5% of our trauma patients, but when it does, it's a problem. About 40% mortality. Some of the risk factors associated with it include high injury severity score, so somebody who has multi-system trauma like our patient who fell 35 feet. The older patient who requires extensive transfusions, the massive transfusion protocol patient, patients who are admitted with hypotension. There are a myriad of other risk factors. These are some of the most significant. Again, we're all very familiar with the Artsnet data, correct? In 2000, a landmark paper published looking at how do we effectively manage and limit the mortality in these patients. When you look really at the bottom line, it's limiting their tidal volume, it's also limiting their pressures. In this algorithm, it's 6 mLs per kilo, which again is Artsnet, but we're going to talk mostly about some of these other adjuncts. Just one thing to also keep in mind, that the definition for acute lung injury and ARDS has changed within the last year or two. The Berlin classification is now kind of the standard reference. When you look at it in more detail, it hovers around the oxygenation, and what was once thought to be mild or acute lung injury is now mild ARDS and onwards. The P-to-F ratio below 100 is severe ARDS. So with respect to a ventilation strategy, you can opt to employ high PEEP. Well, I just told you that the PEEP was 12, the plateau pressures are 38. High PEEP may not be the best thing for this patient, but what PEEP does is it reverses or attempts to reverse the pulmonary shunt that's due to increased lung collapse resulting from the inflammation. It maintains, hopefully increases the functional residual capacity, thereby improving oxygenation. And so with this open lung ventilation strategy, what you'll find is that you will ask the respiratory therapist to turn up the PEEP anywhere from 20, 30 to 40 centimeters of water for about 20 to 30 to 40 seconds. Small randomized controlled trials have shown that it reduces the amount of rescue therapy, so additional adjuncts, decreases the time spent in a refractory hypoxemic, but it does not improve survival. When you look at meta-analyses, depending on what side of the fence you're on, there may or may not be an outcome benefit. This can be short-lived to minutes, so you think, oh, you've done the patient well, it lasts a couple of minutes and you're back to kind of square one. Some of the side effects, remember high PEEP, intrathoracic pressures are high, volume venous return is less, and so there may be some cardiac depression. And then barotrauma, right? We don't want to give this patient pneumothorax or pneumomediastinum. We don't want to start popping lungs. In ARDS, there's no data to show that it does improve outcomes in severe ARDS. And again, remember that the standard of care at this point in time is Artsnet criteria. So if your patient is in ARDS, you really are obligated to adhere to those, to that standard of care. And again, it's low tidal volume, limiting your plateau pressures to less than 30 centimeters of water. And again, very clear evidence that mortality is decreased. With PEEP, you can do additional recruitment movers where, again, you attempt to increase the amount of aerated lung to improve gas exchange. Most commonly, this is with a periodic size. So in the operating room, you'll have your anesthesiologist give a nice big breath. That can be upwards of, 1.5 liters from a tidal volume. Again, keep in mind that it may expose healthy lung to increased pressure and overdistension, and again, barotrauma or volutrauma. Short-lived with respect to the degree of improved oxygenation, and again, transient hypotension. So, but something to consider in your armamentarium. Airway pressure release ventilation, depending on what ventilators you have, may also similar modes of bilevel or bivent, and essentially it's continuous positive airway pressure with an intermittent pressure release phase. So CPAP is applied to maintain an adequate lung volume. It promotes alveolar recruitment for a set time. So you can see on this graph the pressure high, which is, you want to try and limit to 30 centimeters of water. There are clear indications to go above, but again, with compliance issues, you worry about popping lungs, and pneumomediastinum is set for a set time high. The release phase is at a P low. I typically will set it at 0 for a brief period of time, typically less than 1 second. The patient, you can see here, is spontaneously breathing, and in some modes, like bilevel or bivent, that is supported. On the Dragers, it is not supported. This is just a typical waveform and settings. I'm not sure how you guys do your bilevel, bivent, or APRV, but I was trained not to use a P-low because you spend a fraction of a second down there that the patients don't de-recruit. With that said, if you're starting to lengthen out your time lows, you may want to consider adding a pressure or a P-low. I would ask you this, but I don't know that I want to know the answer to that. Certainly in our group of 6 trauma critical care surgeons, there's varied practice patterns. I think in general, if you fall under Hibashi and those guys, a P-low is not set. Again, I may set it if I'm having some difficulties oxygenating, but it's pretty unusual for me to set a P-low. With APRV, it allows, again, CPAP breathing. These patients should be spontaneously breathing, so if you take them out with neuromuscular blockade, you get rid of some of the spontaneous breathing of gas distribution, which will go to the non-dependent areas of the lung. That's really where you don't want to be. You want to be aerating the dependent portion. So allowing a patient to spontaneously breathe allows for dependent lung regions to be recruited, which is where you really want to hit these patients. So there's been a decent amount of literature, certainly not a lot, on airway pressure release ventilation. There's even less literature in our trauma patient population, but Dr. Maxwell here in the top paper from Chattanooga compared airway pressure release ventilation with low tidal volume ventilation, which is the standard of care, and found that mortality, in fact, was unchanged. Small number of patients, I think about 130 total. Recent study presented at East, published in the Journal of Trauma, found that actually if you have a patient on airway pressure release ventilation, they may in fact be on the ventilator longer than on conventional modes. So just keep that in mind. Recent meta-analysis published out of Baltimore found that if you use airway pressure release ventilation early, that in fact outcomes may be improved. Now, this is a meta-analysis. Again, there's not a ton of good data, but those of you who are trauma intensivists, surgical intensivists, anecdotally, as my experience has been, that there's few times that you have to go on to other adjuncts, including the oscillator and rotaprone and those types of modalities. So in this patient, we realized we're getting in trouble. We put him on APRV at our institution. It's bi-level or bi-vent, so I have to set a rate. But in general, P high of 30 is where I will start, a P low of 0, a time high of 5, and a time low of 0.5. Thinking we're doing this patient really well and he's going to go on to do great things. And then we start to have significant compliance issues. You don't see the fractures on there, but they're there. And so this guy he's in definite trouble. So now kind of think what would be your next step at your institution. I can tell you about this time I start to cry because he's a problem. He's a big problem. So prone positioning is one of the other adjuncts. It improves VQ mismatching. It shifts the gravitational forces that may reduce atelectasis. It also minimizes the compression of the lung by the mediastinal structures in the heart. Previous randomized control studies have been small, somewhat flawed, but there's shown some improvement in oxygenation without improved survival. That's been previous studies. When you look at this study that just was published in the New England Journal within, I guess, a year or so ago, looking at prone positioning in severe ARDS, they found actually that mortality was decreased in patients who underwent prone positioning. And so as your adjunct, if you're going to consider this, consider it sooner than later. Some of the contraindications to prone positioning for the burn surgeons in the group. Significant burns makes it difficult to obviously provide adequate wound care. Any sort of severe spinal fractures. Pelvic fractures I don't consider a contraindication, and so we will prone these patients. Circulatory shock, you can't get these patients on there, so that's a no-brainer. Patients with increased intracranial pressure in times past, that group has never really been studied. There was a small pilot study that came out looking at 11 patients that found that you could, in fact, put these patients on the rotaprone without increasing their ICPs. So small pilot study, take it for what it's worth. Some of the big complications, pressures, ulcers, we've all seen them. They are not easy to care for, and the family is, even though you've saved the patient, now they're concerned about this pressure ulcer, so keep that in mind. The endotracheal tube can be displaced. That is a horrible problem when they're sitting prone in the rotaprone. Hypotension, arrhythmias, vomiting, aspiration, all these things. So this is a big deal. If you're going to undertake it early and be prepared for potential complications. We are very nervous in patients who have open abdomens, but you can safely do that. Just make sure that vac is working and make sure you have access to that vac. We did not prone this patient for fears that he would eviscerate, but if you need to do it, you need to do it. Talk about inhaled nitric oxide. It's a selective pulmonary vasodilator. It also improves the VQ mismatching by reducing the pulmonary shunt. It goes to the pulmonary vasculature of the ventilated alveoli only. So improves oxygenation, decreases pulmonary artery pressures, may have some anti-inflammatory effects, but also keep in mind that it may increase oxidative stress in the red cells. It's actually deactivated by binding with hemoglobin. So complication includes methemoglobinemia. Mortality is not decreased. Ventilator-free days are unchanged. So not a ton of good data out there for this. If you're going to start at 5 parts per million, double it every 30 minutes. If you do not have a response, upwards of 40 parts per million. If it's not going to work at 40, it's not going to work, period. Neuromuscular blocking agents. I'm not a big fan of these. I know many of you in the audience are not a big fan of these, but we'll show you a paper that may change that. It prevents patient ventilator desynchrony. It minimizes the work of breathing, thereby improving oxygenation. Previous studies showed no reduction in hospital mortality, and that again, one of the reasons we aren't big fans of it is that there's progressive atelectasis due to loss of the diaphragm. So remember, a spontaneously breathing patient is better able to distribute gas evenly throughout the lung fields. The other issue is ICU acquired weakness or critical illness myopathy. This study just published, I guess just published, 4 years ago just published, in the New England Journal, looked at neuromuscular blockers in early ARDS. And what they found, in fact, was that the 90-day survival was increased, and that the time off the ventilator, so ventilator-free days, but also no increased risk of critical illness, neuropathy, or muscle weakness. So I still don't use them that frequently. It's really a last ditch for me. I attempt to not use it at all costs. But again, early ARDS, you're having problems, you may want to consider a brief trial. This was for 48 hours with cisatracurium. May not be applicable to other paralytics, but keep that in mind. The Oscillator, not a lot of experience, certainly more so with the pediatric population, but provides a continuous distending mean airway pressure around which these pressure oscillations are at a predefined amplitude, so this delta P, at a high frequency, usually around 5 hertz, using this motorized diaphragm. So there's bias flow, oxygen and CO2 are exchanged, the gas is oscillated around this to and fro piston, which is at a diaphragm close to the endotracheal tube. Small tidal volumes are delivered. Atelic trauma is less, in the order of 1 to 4 mLs per kilo. Keep in mind these patients are humming with respect to their breathing, so 300 to 900 breaths a minute. They're going pretty good. URI could not do that, and so heavy sedation, neuromuscular blockade needs to be considered. These pressure oscillations, just remember that the alveoli, by the time it reaches the distal alveoli, that pressure is dampened, and so alveolar trauma is less likely to occur. And again, it maximizes lung protective strategies. So maintains alveolar recruitment and oxygenation while using small tidal volumes, less than anatomical dead space, which minimizes some of the swings in alveolar pressure that the alveoli do not, that the distal alveoli do not get. Reduces volume trauma and atelic trauma. Only meta-analyses prior to the last couple years had showed any reduction in mortality, but isolated studies in and of themselves did not show a decrease in mortality. When you look at the Oscillate study and the Oscar study that were just, again, published within the last year or two, there's this big push in the adults in times past. There wasn't a big mortality benefit, and these two studies seem to confirm that, in fact, hospital mortality may be increased, certainly of no benefit compared to conventional ventilation. So if you're an Oscillator fan, you might want to back off a little bit on some of your patients with severe ARDS. Two very well done studies. Oscillate trial stopped for intent to harm. The last mode we're going to talk about is ECMO. So again, another lung protective ventilator strategy where mechanical ventilation is dissociated from gas exchange. So oxygen and CO2 are removed through an extracorporeal circuit. The lungs are supported with conventional mode of ventilation at lower tidal volumes, low pressures, allowing the lungs to heal. Gained significant presence in the literature around 1979, although mortality was quite significant at greater than 90%. In 94, a randomized controlled study showed no difference in mortality compared to pressure control inverse ratio. JAMA 2009, we're all familiar with the H1N1 outbreaks. The Australians and the New Zealanders published a series of patients. The survival actually is 70%. It's closer to 75% when the patients are placed on ECMO before 7 days. After 7 days, mortality goes down, or chance of survival goes down to about 30-35%. So if you're going to remember anything about ECMO, you've got 7 days to get them on it. The Caesar trial, published in Lancet in 2009 from the UK, compared ECMO centers versus centers with less specialized care that underwent conventional modes of ventilation. That in and of itself should tell you, okay, there you go, should tell you that there is some standardization issues and some bias, but found ultimately that patients had improved chance of survival if they underwent ECMO and underwent it early. Just remember, only 8% of the population we care for were included in that study, but still a significant finding. And also remember, this was a pathway of care of ECMO, not looking at ECMO in and of itself. So at least we know that protocolized care with ECMO, there is a mortality benefit. There are two forms of ECMO. There's venous arterial and venous. For patients who are primarily pulmonary cripples, the VV ECMO has less complications. VA and doesn't support the circulation, whereas venous arterial ECMO does. This diagram, and typically the catheters, there's a large garden hose stuck in your neck and in your groin. Oxygen is pulled out, it's oxygenated, blood is pulled out, it's oxygenated, CO2 is removed, and it's distributed within the venous system. That's usually the single cannula. Here's a double cannula method, which has been just approved within the last couple years. Two large bore garden hoses out of your neck, but allows the patient to be more ambulatory and exchange via the pump and the oxygenator. So some of the complications are typically due to hemorrhage. This is a patient with obviously life-threatening hemorrhage on autopsy, but it's due to the systemic anticoagulation that's needed to prevent the system from clotting. Intracranial hemorrhage, about 10 to 15%. Most interestingly is pulmonary hemorrhage, which is the most common, and then GI bleed. So I know there are 3 centers in town that have a significant experience with this. This is not something that you should just be dabbling in. It's really something that needs to go to one of these higher centers. So back to our patient who fell 35 feet and was sick as a dog and injured everything. We didn't prone him initially because of concerns for the open abdomen. We did put him on nitric oxide, which he did respond to, and we opted to paralyze him for about 24 hours during that period of nitric oxide. Interestingly enough, his respiratory status improved, but then he developed a fungemia, which then ultimately took his life. So anyway, some of my recommendations borne out by the literature: if you're going to use APRV, bilevel bivent, do it earlier than later. Everything else you kind of got to consider. If you're going to do it, try and do it sooner than later, whether it's a prone position, open abdomen or no open abdomen. Using nitric oxide, neuromuscular blockers, 48 hours at the most. Maybe not consider the Oscillator, although depends whether you buy into those two pretty well done studies. And then certainly ECMO, even though it's last ditch, it's something that you may want to move up higher into your algorithm, because when you get to using these 4 or 5 adjuncts, it may just be too late to transfer the patient to an ECMO center of care. So thank you. Thanks for the opportunity.